Let's, in the last few minutes, talk about the fact this patient has a pre-existing autoimmune disorder with lupus.
Lupus is a tough one.
Yeah, but well controlled, not on any medicine. We saw from the data that we presented, this paper that has come out of both your institutions, retrospective analysis looking at checkpoint inhibitors, 56 patients, flare rate 20%. I mean, are you comfortable treating this patient with well-controlled lupus on immunotherapy, given that we have nothing post-consolidation for consolidation outside of immunotherapy for these patients?
So I probably would, just because so far the PFS benefit from Pacific was so high.
Yeah.
So I would be willing to take the chance after going through the risks in great detail with the patient. And I'd watch his renal function.
Yeah, so the JCO paper was, I mean, it's good to add to the body of literature. I think it's problematic insofar as most of these patients still had a relatively not terribly severe autoimmune disease,
That's
rheumatoid
right.
arthritis, for example,
Yeah.
right? And not a lot. So there was a smattering that had things like ulcerative colitis, and but the kinds of the spectrum of autoimmune diseases was tilted towards things that are not as clinically severe when they flare in particular, right? And I think that limits our ability to figure out what to do when you have a patient with, ulcerative colitis, Crohn's disease,
Right.
or even lupus, and I think a lot of anecdotal experience will come into play with this. And we were talking about this earlier, but there's a patient of mine who had discoid lupus, so cutaneous manifestation, 15 years before, and it went away very quickly, seen by a rheumatologist very frequently. And so we had a discussion with the rheumatologist about, the availability of immunotherapy. This is stage 4 patients, not exactly like this. PD-L1 was high, 80%. And so pembrolizumab would be a standard for her. And the rheumatologist did a panel of serologic tests. Nothing came back positive. The patient was feeling great. We gave her pembrolizumab, and then she got basically lupus, and in a bad way, with a lot of dyspnea and sort of arthralgias and fatigue, and that quickly went down with steroids. We thought, okay, let's try it one more time because it went away very quickly, and it was worse the second. So clearly, this the immunotherapy uncovered this process, which was dormant. And I think, it really is a risk-benefit discussion with the patient. I think it begins and ends with that, really. Right?
Would you do a risk-benefit discussion with this patient with lupus about the role of immunotherapy?
I would actually. It's hard. Part of the difficulty, I think, with the Pacific trial is that for those patients who recur, the standard is already shifted under us, right, during the lifetime of this trial in terms of what we'll talk about later, Keynote 189, 407. So exactly what is the interplay with the OS advantage in particular? And that really is the key piece of data in the context of newer, better, arguably better first-line therapies for patients with recurrent disease. Where do you need to be so concerned now about giving them some consolidative therapy in the freebie setting? When you have something in the first line, metastatic setting that might work very well for them. These are all sort of things that come into play in that discussion.
All right. Any other considerations? I think it was an excellent discussion about the case, and really the case highlights some of the challenges we face in the clinic every day. So let's move on to case 2, which Paul will be presenting.